The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us in person or virtually at annual.apic.org.
You're listening to the 5-Second Rule, brought to you by APIC, the Association for Professionals in Infection Control and Epidemiology. Together with our nearly 16,000 members, we strive to create a safer world through the prevention of infection. Join us while we talk to infection preventionists and other experts to learn the truth about some common myths related to the risk of infection and to get tips to keep yourself and the people around you safe from infection. Welcome back, everyone, to another episode of APIC's The 5-Second Rule. I'm Silvia Quevedo, your host, and today's episode is Renal Failure is Not an Option, Infection Prevention and Control in Dialysis. So we have a lot to unpack today. There's a lot to discuss in dialysis and kidney failure. Hopefully those of you who are listening that are not infection preventionists can have a few takeaways. Many of us know or have family members that are dealing with dialysis. Perhaps they've had the misfortune of having end-stage kidney disease. And so today we're going to talk a little bit about what we can do to help those individuals not get sick or sicker. So let me set the stage before I introduce our guest. In the United States, according to the University of California, San Francisco Kidney Project, there are almost 750,000 people in the U.S. that have kidney disease. Unfortunately, there's some disparity in that number. African Americans are 3.5 times more likely to have kidney failure. Native Americans are 1.5 times more likely to have kidney failure, and Hispanics in this country are 1.5 times more likely to have kidney failure. And so it is important for us to understand this disease. It's important for us to understand some of the issues around those disparities, and that mortality rates vary according to the treatment. And so, again, according to the University of California, San Francisco Kidney Project, after 1 year of treatment, those with dialysis have a 15 to 20% mortality rate, with a survival rate after 5 years of 50%. So those are pretty dismal. And you know, we want to make sure that we make improvements in this area. So to help us understand why this is happening, we have Tara Millson. Hi, Tara.
Hi, Silvia.
Welcome to the 5-Second Rule. Tara, you are the Director of Infection Prevention at the George Washington University Hospital, and you're a certified in infection control, and I know you recently received your Doctor of Nursing Practice in infection control from Loyola. So I know you know a lot about this. And by the way, Tara is also very active at APIC, and she currently serves as the vice chair of the APIC Practice Guidance Committee. And so, first of all, thanks for being with us. And tell me, your background is also in nursing, correct? Before you became an infection preventionist?
That's correct, Silvia. I had about 10 years of bedside nursing on a cardiac unit, and then I switched over to hemodialysis for a couple of years while I was working on my bachelor's degree because the hours were good. But while I was there, I really developed an interest in the population because of just the chronic nature of their disease, the fact that dialysis completely replaces a failed organ. It's amazing. It's the only treatment modality we have to replace a failed organ. And people can survive a really long time on dialysis, but it's not without consequence. After my stint in dialysis, there was when I moved into infection prevention. And when at my very first infection control committee meeting, I realized that the nursing administrator from dialysis was reporting on dialysis infections. And so I asked my director why we weren't involved in the dialysis program. And that's when I learned that CMS does not require infection preventionists in the dialysis setting.
So, Tara, I'm going to interrupt you. CMS being the Centers for Medicaid and Medicare Services?
Correct.
Okay. So they don't require that.
They do not. And so that was kind of what really launched my professional pursuit as an infection preventionist to improve the care of dialysis patients.
So, Tara, let me ask you, because I threw out a lot of numbers to sort of, get everybody grounded. But let me just repeat that or add a few more. So according to some data that I have read with the CDC Surveillance Project, again, the University of California, San Francisco Kidney Project, there are a lot of sources. But as of 2018, there were 7,433 dialysis facilities across the U.S., where a little over 500,000 patients receive dialysis. I quoted at the beginning 750,000 people in the United States with kidney failure, disproportionately affecting people of color and other minorities. This is huge. This is a big number. So it behooves all of us to really understand kidney disease. So maybe let's take a step back and perhaps educate those of our listeners who are not infection preventionists or healthcare workers and help them understand just the basics. So why would someone need dialysis, right? You said it's the only modality that completely replaces an organ. So just really treat me like I'm in first grade. Tell us a little bit about the basics of dialysis.
Sure. So end-stage kidney disease is the disease that requires dialysis because the kidneys stop functioning. But before you get to end-stage kidney disease, you have chronic kidney disease, which is abbreviated as CKD. And this is very prevalent in the United States population. And there's five different stages. And most of them have no symptoms and actually go undetected and undiagnosed until the person gets to those later stages where they start to need dialysis.
So there are a lot of people walking around not knowing they have this.
This is correct. You mentioned that a lot of them are minority patients, and that is absolutely true because of the diseases that usually lead to kidney failure include diabetes and hypertension, and both of those disproportionately affect persons of color. And so there's also some, access issues, some limited access issues to primary care, which also disproportionately affect those groups. And so that's why they tend to not know about their advanced kidney disease until much later in the process.
Okay, so it is important to understand that you can have chronic kidney disease and not know about it. So it is important to ensure that you're checking your blood sugar levels and checking your blood pressure so that you don't end up with diabetes and or hypertension. Okay, so you go from chronic to then end stage. Then what?
So that is the point where your kidneys can no longer get rid of extra fluid, and they also lose their ability to regulate the some of the electrolytes in our blood, such as potassium.
Okay, so I'm going back to high school biology. So our kidneys filter or flush out all those impurities from our blood system. Yeah. And they're pretty small, right? They're like a couple of inches. How big are our kidneys?
I don't know, maybe about 4 inches or so. I think they're about the size of your fist. And there's two of them located on each side of your body, on each side of the spine.
Okay. Just needed that Kidney 101 end stage renal failure 102 or something. Okay, so the dialysis process replaces the kidneys.
Correct. Not perfectly, but well enough that people can live for many years with a failed organ.
Okay. So, I mean, here's the question. We know, obviously, individuals with end-stage kidney failure have a lot of comorbidities or other illnesses that impact them. But talk to us about dialysis and what that looks like for the majority of people in the U.S. in terms of how it's delivered, the frequency, where it's delivered, and some of the infection prevention and control challenges.
Okay, that's a lot to unpack.
That's what we do here.
So for most people with end-stage kidney disease, they will be treated with hemodialysis. There's a few other treatments, including peritoneal dialysis, which does have some infection prevention considerations. So we'll talk about that a little bit. And then also a pretty good number of patients end up getting kidney transplants too. But for this, I want to focus more on the hemodialysis. So for most patients, they'll require treatment 3 days a week. And each treatment is 3 to 4 hours in length.
Wow.
And most of the time it is performed in one of those outpatient settings. I think greater than 98% of patients on dialysis get treatment in an outpatient setting versus the home.
Okay, and that's pretty much explains the over 7,000 facilities around the United States. You would go to this outpatient place and sit for what, 4 hours? That's a really long time.
Yeah. It is a really long time. And if you can imagine how much that would disrupt your life because you can't travel, many people find it difficult to work. It can really impact your home life and your responsibilities that you might have to children or parents or other caregiving responsibilities. So it really is, every single week, this really tremendous burden for the patient.
Okay, so what happens? You go to this place and they hook you up to the dialysis machine?
Correct. So most of the dialysis patients will need some kind of access to their bloodstream. And because it happens 3 times a week, we try to use something that's permanent or semi-permanent so that we don't have to keep poking them over and over trying to find new sites. You also need a very large blood vessel because of the amount of blood that is flowing in and out of the needles, which is about 0.5 liter per minute.
Oh my God. That's a lot.
Yeah.
Okay, so really, everybody, take care of your kidneys because this is rough. I mean, either 3 hours sitting in a chair with a blood vessel that's exposed. Okay, so those are the basics. Talk to us, Tara, about, we hear in the infection prevention and control space, this is a setting and population that is very high risk for infections.
That's right, Silvia. People with end-stage kidney disease, because of the physiologic changes from that, are more susceptible to infection, more susceptible to severe infection, and from mortality from infection. They don't mount as robust a response to any pathogens, and they also don't really develop antibodies to vaccinations as well as a non-end-stage kidney person would. So that leaves them vulnerable to infection. But the access that I was talking about earlier to the bloodstream, most patients, greater than 80% of people will enter dialysis with a catheter, a venous catheter, a central line, which we know greatly increases the risk of an infection from that because it sits outside the body and there's a direct portal into that bloodstream at all times. Some other access includes a fistula or a graft, which is implanted under the skin. So there's less risk of infection with those. Okay.
So they're at risk by virtue of their disease. They're at risk because they have their blood vessel is accessed. So why are there challenges in this setting? I mean, you said earlier CMS doesn't require it. Do we anticipate changes to that rule? Obviously, we say this all the time on the 5-second rule. People go to work wanting to do the right thing. What's happening at the point of care in dialysis where infection prevention and control practices are less than ideal?
Yes, that's a great question, and something that's been studied pretty extensively, because we do know that infection prevention and control best practices are not uniformly implemented or followed in dialysis facilities. Some of that may be explained by the lack of an infection preventionist, because we're really the experts in that evidence-based practice and implementing those practices. And I think recognizing that, and I think it was about 2010, where the CMS put out a request for comments in their Federal Register, and they wanted to propose that an infection preventionist be required in dialysis, but the overwhelming response from dialysis companies, and it's important to note that most dialysis is provided by these two large for-profit companies. The rest, I think about 20%, are either in provider offices or smaller regional clinics. But anyway, so the response to that was that there just wasn't the manpower. There wasn't the ability to dedicate a nurse to infection prevention, because usually the number of nurses are very small, and to recruit an extra nurse when there's a nursing shortage would be difficult.
Okay, but let me interrupt you and stop you there. So, I mean, who's doing this in these facilities?
It's under the direction of the medical director, is ultimately responsible, but it's usually delegated to somebody else, either a charge nurse, or I've even seen unit secretaries that are the ones responsible for implementing and reporting and surveillance of infection.
Okay, so just so I'm understanding, you go to your dialysis facility, which is likely in the U.S. anyway, at an outpatient facility that is owned, operated by a for-profit corporation, of which there are a handful, 2, 3, maybe big ones here in the U.S.
Mm-hmm.
And so there's a medical director that oversees it, but literally you're sitting in the chair. Who's hooking you up? Who's helping you? Who is that person?
Sure. It's typically a nurse or a technician, a dialysis technician, and they are usually unlicensed but well-trained.
Okay. But not necessarily an infection prevention and control.
No.
Aha. Okay. So what you're saying is, because there's typically not an infection preventionist, or the people working there don't have tons of training in this area, IPC, or infection prevention and control.
That's
all
correct.
Right. Okay. So how do we change that? That's a problem.
It is a problem.
So, Tara, let me ask you, because you said you worked a little bit in nephrology nursing. What is it that is happening to these patients? What kinds of infections are they getting? What pathogens are we seeing in this population? And where do you, in your experience, where do you see the breakdown in the infection prevention and control practice? So in other words, we know they're not really trained, but where are you seeing the breakdown?
Okay, so I'll start back with the first part of your question, which is the kind of infections that they're getting. So most often when we're talking about infections or HAIs, we're talking about bloodstream infections. This is the most common HAI to affect dialysis patients, largely because of those central lines that they have, the fact that they're accessed 3 times a week for long periods of time. So, and each time it's accessed, there's a set of interventions that need to be performed, like skin antisepsis and hand hygiene and barrier precautions that need to be followed perfectly every time. But just because they're there 3 times a week and there's so many of these interventions, any one that is missed puts them at an increased risk of an infection. Another common infection in dialysis patients is hepatitis C. This is more common in the dialysis population. In fact, it's the one chronic infection that's actually increasing in the United States, whereas everything else is comparatively decreasing. So hepatitis C is bloodborne, and because of the nature of dialysis, there's so much blood around. There are outbreaks of hepatitis hepatitis C still occurring in the United States because of these breakdowns in infection control, most notably hand hygiene or surface disinfection.
So they're just not performing it. Like we talk again, you can never get past an episode of the 5-second rule without hand hygiene. So that's not happening, or adequate skin antisepsis, or what they're using is not appropriate. And by the way, skin antisepsis is just wiping down the area that you're going to work
That's
on, right?
correct.
We have to assume some people might not know all our fancy words. Okay, so what's happening there? They're just not doing it, or they're doing it?
So what we find is that there's often some skipped steps, shortcuts taken. People just kind of get into a routine. They start skipping a step. They see nothing really happen, so they just continue to skip those steps. And it typically is due to time pressure. These dialysis facilities will work in shifts. So they'll bring in a group of patients at 8. They want everybody off the machine at a certain time, and then they'll bring the next group of patients in, at 12 or 1. And in order to stay on schedule, there often isn't enough time between those patients to adequately perform disinfection and to adequately perform all of the steps to put the person on and take them off the dialysis machine. So we do find sometimes shortcuts are taken.
Okay. All right. So what do you think is the best remedy for this?
I think one way is the use of checklists. Checklists have been very effective in reducing bloodstream infections in central lines in acute care. And we have known about this since about 2008 with a couple of different initiatives, that when a checklist is followed, all of those steps are completed reliably. And so there actually are some checklists that were developed by the CDC, and they're available on the Making Dialysis Safer for Patients Coalition website. And there's a series of checklists that can be used to both either at the chair or the bedside by the clinician, or used by the administrative staff to verify competency with their nursing staff.
Okay, so someone checking that they're doing all the right things, and then the caregiver also ensuring that they're following each step. That seems pretty simple.
It is simple. The key is just getting people to do it. I think a lot of times, especially with dialysis where it's routine, you do the same thing every day over and over and over. And so that's how those shortcuts can be kind of baked into their practice. So the checklist, if you post them near the point of care, become a really good reminder of those steps that are missing, or just a visual way for people to verify that they're doing all of the steps correctly.
Okay, so if you are a nephrology nurse or a technician listening, you might want to propose that for your dialysis center. Let me ask you, you mentioned something about home dialysis and peritoneal. Talk to us a little bit about the difference there, and what does that mean, and why would someone get one instead of the other?
Sure. So with home dialysis, this is very infrequently used because of the risk of with the bloodstream being accessed at home. So the person has to have what they call like a safe person at home. So they have to have somebody who lives with them, who is competent and reliable to assist if there's an emergency, and to help with the connection and disconnection. We also, because they're not trained medical professionals often, we have to make sure that they understand that antisepsis we were talking about. So the prevention of infections, and making sure that they disinfect appropriately each time, so that they don't accidentally cause an infection in themselves. So typically the home dialysis is a little bit gentler. It's usually run at night, so the person can sleep while the dialysis is taking place. And it's a little bit of a gentler process than the 3 times a week, where it's the abrupt shift in fluids and electrolytes. And people really like it, but it's not always accessible, either because there's maybe sometimes some insurance issues, or having a person at home that's able to help.
So is the difference really insurance in that, or is it actual level of disease severity?
Well, that's a good point, because often these patients will have other comorbidities that make them unlikely to be able to do this at home. So, by the time they have end stage kidney disease, this is an end organ damage. They might also have damage to other end organs, such as, for instance, the brain. Unfortunately, they might have suffered a stroke or something else that's equally devastating. So in those kinds of cases, it would be inappropriate to treat them at home. This would be somebody, without those sequelae.
Okay. So what about peritoneal dialysis?
Yeah. So peritoneal dialysis is a great option too, because this is done through the peritoneum, which actually acts like the dialysis filter. So the person's own tissue is what exchanges the fluids and the electrolytes. They infuse fluid into their abdomen. It dwells for a period of time. It's often done overnight or even during the day. And then they just empty it out. And that is how dialysis is performed. It's much gentler as well because you don't have that rapid shift of fluids. And so people tend to like it. And they can usually carry on a somewhat normal life because they can still go to work. They can still be at home doing their normal, responsibilities and activities. One of the major risks with peritoneal dialysis is the risk of peritonitis, which is a serious infection of the abdominal cavity. And because of the peritoneal dialysis tube is implanted directly into the abdomen, and that's close to some areas that tend to be a little bit dirty, like the groin. And there is potential for infection of the peritoneal dialysis catheter.
Okay. So who gets that versus who gets, 3 days a week at the center?
So again, it'll have to be somebody that is able to perform all of the procedures. So they have to be done, aseptically. They have to be done reliably. So you need somebody that's going to be compliant and be able to do all the follow-up, because it requires some follow-up with physicians as well.
Okay. So, wow. I mean, of course, this is a huge topic. We're only scratching the surface. But Tara, talk to us about the infection preventionist, and, how are they addressing infection prevention and control issues in dialysis? Because, I've heard that there are many IPs who get nervous when they have to step into the dialysis setting. What kind of training, or what are some things IPs need to look at and look for to make things better?
Sure, that's a great question. So just to go back to my earlier comment, we talked a lot about outpatient dialysis, and they don't require an infection preventionist. But one place where an infection preventionist is likely to encounter dialysis patients is in acute care. So these dialysis patients are admitted on average to the hospital twice a year. And while they're there, they still need to receive their dialysis. So this is one place where the infection preventionist is going to see dialysis patients for sure. And they do have a responsibility to the dialysis program that's in their acute care setting. But one thing that we find is that infection preventionists tend to be a little bit scared of the dialysis patient or the dialysis unit because it's kind of technical. It's very almost like a specialized skill that they feel like they don't understand. And so they don't feel competent to go in and assess the infection control practices in the dialysis setting.
Well, I know there are those big machines, which is pretty amazing if you think of the size of your kidneys, that these humongous machines, do what your little 4-inch kidneys do. But is it that? And is that really just a perception that maybe when they get in there, they understand, okay, yeah, it is important that, everyone use hand hygiene, that there's skin antisepsis, that, there's a central line, essentially. What do you think the problem is in terms of, is it just familiarity, or is there really a fundamental gap in infection control knowledge? Or do you see what I'm saying? Is it a perception because they've never been in that setting, but they really do have the fundamentals, or they don't have the fundamentals and that we may need to shore up some of that competence and knowledge?
Well, I think that the infection control and infection prevention principles are the same, regardless of setting. But, from the infection preventionists that I've talked to personally, there's often a feeling like, I don't know what's happening here, and I don't want to be here. I don't feel confident to assess what is happening. The steps are a little bit different. They have a lot of blood coming out. It can be kind of, scary if you don't know what you're looking at. But I think it's important for infection preventionists to remember that the core principles are the same, of disinfection, of central line care, because that's really what we're talking about when we're talking about hemodialysis, is how well they take care of that line, because that is what is most often the source of an infection in a dialysis patient. And I mentioned earlier the Making Dialysis Safer for Patients Coalition, the CDC, which with a series of checklists and audit tools. And this was something that I used when I developed a surveillance program for a dialysis setting to assess the competency of the infection preventionists, because this way they felt comfortable with what they were looking at and what they were looking for, because all of those steps are outlined on an audit form. And so it's simply, was it performed or was it not performed? And I also find that dialysis nurses love to share their knowledge. And so I have never had a single instance, and I've been in a lot of dialysis clinics, where a nurse has said, no, I can't talk to you. I don't want to talk to you. They love to share their knowledge. So if you simply just say, you know what are you doing? Is it okay if I watch? Can you walk me through this? More often than not, I think you're going to have a positive response to really just learn what is happening in the dialysis setting.
Okay, that's helpful. And so, those IPs out there, do that. Step into the fear and talk to your nephrology nurses. Tara, talk to us a little bit about dialysis patients during the COVID-19 global pandemic. Have you seen anything of that we should be concerned about?
Sure, that's a great question, Silvia. So one thing is dialysis patients were not able to stay home, right? They still had to go out and go to the hospital and take, sometimes Ubers or taxis to get there. And so they were already at increased risk of getting the infection. But then we found that dialysis patients who got infected with COVID had a very high mortality rate, approaching about 40%.
Wow.
Mm-hmm. And another interesting thing that we were unprepared for was the number of COVID patients who were not kidney patients who developed acute kidney injury while they were in the hospital. It was more than 50% of patients, COVID patients in ICU, suddenly needed dialysis.
Wow.
And so nationally, we had a shortage of dialysis machines, dialysate, some of the products that are used for dialysis. So there was actually a new modality that was developed called acute peritoneal dialysis. Typically, peritoneal dialysis is done in the home, and it's something that's kind of chronic. But we found ourselves having to do acute peritoneal dialysis on ICU patients. So it was interesting.
Wow. Yeah, just another bad outcome of the COVID-19 pandemic, but definitely something for us to pay attention to going forward, and more research needed on that. Wow. Tara, my God, we scratched the surface. We're going to probably do a round 2, of dialysis. Couple of things, though, I want to make sure our listeners have, and that is, be sure to check out, as Tara said, the Making Dialysis Safer Coalition, and that is available on the CDC website at cdc.gov/dialysis/coalition. Anyway, just put Making Dialysis Safer. And that's also going to be important for families, right? Because I think they'll get some really good information.
That's correct. And we can't ignore patients and their effect on their own infections. And so there's a lot of resources on there for patient education or caregiver education. And that's a really important, and actually one of the core interventions to preventing infection is to make sure that our patients are educated in how to prevent infections.
Yeah, we say that all the time. Infection prevention and control is everybody's business. Tara, thank you so much for sharing your expertise and, of course, your time with the 5-second rule. And heads up, Tara is also working with APIC on an updated implementation guide for infection prevention and control in dialysis, which we hope to get out and made available to everyone. There's lots of education, so everyone please check out www.apic.org. And a big thank you to Tara Millson.
Thanks for listening to the 5-Second Rule, produced by the Association for Professionals in Infection Control and Epidemiology staff and the APIC Communications Committee in partnership with Human Factor. Audio tech is Blake Alphin.